In this special episode of the ASC Podcast with John Goehle, recorded live from the California Ambulatory Surgery Center Association's 2025 conference in San Diego, California, we interview some of the speakers and discuss recent events for the association and the benefits of membership in the association.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs, and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 254 of the ASC Podcast with John Goehle for September 5th, 2025, recording from the California Ambulatory Surgery Center Association's 2025 conference in San Diego, California, and from our studios in Spencerport, New York. This is Sue Cronkite, co-host of the ASC Podcast with John Goehle and operations manager for Ambulatory Healthcare Strategies. We would like to remind our listeners that the ASC regulatory environment is a rapidly evolving landscape, and the material presented in this episode is based on the most current information available as of the date of recording. As such, it is important to recognize that this information may be subject to change, and we advise all ASCs to stay up to date with the latest regulations and guidelines issued by the relevant regulatory bodies. Joining me today is John Goehle, the owner of Ambulatory Healthcare Strategies and one of the most respected experts in the ambulatory surgery industry. With over 30 years of experience, Mr. Goehle has authored over 10 books on the ASC industry, and he is a sought-after speaker on regulatory accreditation and finance issues.
So as usual, the CASA conference was a big hit. It was a lot of fun. Sue, you weren't able to join me out there, but it was quite an event. Kind of unusual. I haven't been in San Diego in a while. And one of the things that was unusual about it is that the exhibit hall was in a tent outside of the hotel. Now, when I say that, it makes it sound like, this temporary tent. It really was sure. It had air conditioning, and it was definitely set up for this long term. But it was unique and really a heavy turnout of surgery centers and leaders, as well as really a great exhibit hall. And if you're a vendor and you haven't been to or signed up to be at the CASA conference, it really is one of those go-to conferences that you need to be at, especially given that California has more surgery centers than any other state. Also, which is always important to me, they had a wonderful party at the end of the Thursday night. Sue, they had dueling pianos.
Oh, really?
I always love those dueling pianos. It was a lot of fun. It was outside. The weather held up, and we had great food. But I'll tell you, what it really comes down to, of course, is the conference itself. The wonderful sessions. It was a very diverse mixture of content. And they did something very unique this year, which I was proud to be part of. For the pre-conference, they had basically a cask review course. It wasn't called that, but it really was a preparatory conference or session to help people to determine whether they're really ready to take the cask exam. And then they followed it up on Saturday with an actual live exam, which is the first time that's been done since the Board of Ambulatory Surgery Certification moved to a computerized mechanism, where, in other words, where people go into a center and take the exam on the computer. So, and Sue, I think there was about 100 people at the pre-conference for this. So certainly there's a demand, and I think this is a good lesson for other state associations out there. I think there is a heavy demand for that type of training, that kind of oversight of the responsibilities of an administrator, and hopefully a preparation for people to take the exam. I did have an opportunity to interview a couple speakers there. It was difficult, Sue, because many of the speakers were nationally, worked for national companies.
Yeah.
It's difficult without preparation to get them, their organizations to approve them speaking. So that's why we don't have a lot of interviews, but those that we have were fantastic. So our first interview was with Greg Tertez, and Greg is a pharmacist. He's with ASC Pharmacist Consultants. They are our go-to people on the West Coast, at least in California. And Greg and I have been in touch for a number of years. We've often spoken together about regulatory issues, and he did a session on a culture of security, preventing DEA schedule medication diversion in the ASC. Interestingly, I was telling Greg that Sue and I, that the two of us speak quite a bit about drug diversion, and we bring it up quite a bit on the podcast because unfortunately it is a pretty common situation. So I often wonder whether we're overdoing it. In other words, if we're talking too much about it. But then I say that, and I think that same day we heard about another drug diversion in one of the centers. So I think this is always a timely conversation. So let's listen to Greg as he talks about preventing medication diversion in an ambulatory surgery center.
So I'm here at the CASA Conference 2026, and we're in San Diego. I'm here with Greg Tertez. Greg is a pharmacy consultant based on the West Coast. He's my West Coast guy when I recommend people for a pharmacy, and he's doing a presentation on diversion in a couple hours here. So I thought I'd bring him on the podcast here and talk about whatever he wants to talk about. Of course, part of it will be certainly diversion, but there's so much going on in pharmacy right now, and it's such a tough area. Greg, as a surveyor, it's one of those areas that I do find citations quite a bit for various reasons. And I'm not sure everybody really takes security as well as they should. And I know that's one of the conversations that you're going to have with the audience, is the importance of understanding that diversion does occur, and it's not uncommon in our setting even. So introduce yourself, and then let's talk.
Okay, John. Thanks for having me on. My name is Gregory Tertez, pharmacist consultant. I've been practicing here in California with surgery centers for about 13 years now, and I'm in over 100 surgery centers, and that's all I do every day is consult to ambulatory surgery centers. The reason I'm here at CASA talking about diversion prevention is because the organization requested it.
Yeah.
They said our members are always asking about how to prevent controlled substance diversion. So I've taken the conversation and I'm working very hard at lifting it out of what things do I do? What's the tracking? What's the paperwork look like? Yeah. I'm trying to lift it out and encourage my centers to have a culture of security approach. It's larger than just I have to check things, I have to count things. It's larger than the count twice a day.
Yeah.
Now, of course, we have to be very good at all the steps involved, and we want to have each step include essentially an inferred message saying this is not a place you're going to be able to get controlled substances from. If you are looking, because statistically, if you have 10 people in the building, one of them through their life is going to be looking for or abusing medications of some kind.
That's a scary statistic. 10% of the population
10% of the
during
population,
their lifetime.
and that includes alcohol, prescription drugs. But you never know if someone's at home abusing alcohol. You never know if this is the month that their spouse says, we're done, and now they're looking for something stronger. You never know.
Right.
And if they're on the edge of that, they are scoping you out in a way that they're looking at your center in a very different way than you do.
Right.
And so from our perspective, which we can't think like that, but from our perspective, we want to make sure we are locking it down, but not just locking it down, making it very clear to everybody that it is locked down.
Yeah.
So the culture of security isn't just, we tell the anesthesiologist how that they're getting 10 fentanyl and 10 midazolam on this piece of paper, but also we hand it to them in a box that is locked with a key that they are the ones with the key and they are responsible for that for the day. When they are not in front of it, they have to lock that and take that key with them.
And there's a clear line of movement of the drugs there to know exactly where something would disappear.
Documented on either the paper or electronic form saying this was passed to this person. Yeah. And at the end of the day, we are saying they started with 10, they gave 1, 2, 3, 4, 5, 6, 7, 8. There's 2 left. Indeed, there are 2 in the box, and I am now transferring 2 back into our control stock. And so we have to do all of those steps. Yeah. The other piece is if I get the phone call at the end of the day and they say we're missing 1 fentanyl, sometimes part of it is, okay, we have to do research. We have to identify if it's theft versus not theft versus, what happened. Can we find it? I was talking to somebody here at the conference this week about how in their center, if there's 1 missing, nobody leaves the room until they find it. Now, in California, some of the culture is anesthesia drops the box and runs away. Yeah. I prefer it that they are there for that final count and they have to sign with the nurse at the end. But, that's the direction to move, the best practice. It's not always the practice. But if there is 1 missing at the end of the day, we don't keep that secret. Right. And
you act on it right away. You don't wait till the next day.
You act on it immediately. You do your research. You do your incident report. You put that into the employee files of anyone involved or credentialing files of anyone involved. So if there's a pattern in a year or 2, we will see that on paper. Right. But also, in addition to acting on it immediately, doing all your research, exactly identifying what's happened, you also let everybody know it happened and that you caught it. Right. And so if somebody was trying to find a loophole, they have now been shown they got 1, they got away with 1, but that's it. Yeah. They aren't getting any further. Again, the culture is that not just that we lock it down, but people are still, even with everything in place and doing it really well, people still try things. I got a call 2 weeks ago from one of my centers that does things really well. And yet, at the end of the day, a fentanyl was missing. All the research turned out that the anesthesia provider had, it was a midazolam. The anesthesia provider had brought it into the laser room thinking a patient might be nervous. And then they didn't use it. And it was in their scrubs at the end of the day. Oh, wow. Now, should that have been caught by the anesthesia provider when they were checking their sheet at the end of the day? Absolutely. But they didn't. But we were, we got the call. I guided them through the process and was explaining the whole process. And it included contacting the provider, which they had not done yet, who had left already. And then following that research all the way down. Yeah. So you never know whether it's, I call these behaviors of diversion. When the count is off at the end of the day, that's a behavior of diversion. It may be diversion. It may be less nefarious. Yeah. And so you don't know until you jump in and start searching and figuring it out.
And you don't make the assumption right from the very beginning that it was not a diversion. In other words, you take all the steps necessary.
You do make the assumption that it's diversion.
Well, right.
Until proven otherwise.
That's exactly. Yeah, that's what I meant. Yeah, no, I agree with you.
Exactly.
And don't wait, because the longer it takes, just like anything in life, the longer it takes for you to act on it, the more likely you're not going to be able to resolve it quickly.
Absolutely. And when I do get the call, hey, Gregory, last week this happened, I'm at a loss for how, because even then, if it was theft, you're supposed to report within a couple days. Right. So you've missed that already by not doing that research. You've got to do it right away. for that example, if it was in the scrubs and they hadn't done it right away, those could be taken out for washing, and you never would have found it, and it would have been a mystery.
Or get a very difficult call from the scrub company, which is even worse.
if they find it, yeah.
Yeah. So there's so much to unpack here. Why don't we let's talk about the DEA right now, first of all, because I don't think that's something that I completely understand, because I always rely upon you guys to tell me. But that's the scary part of this, and I think it's important for your centers, for our listeners to know what are the consequences of a miscount or diversion or drugs that you can't even figure out where they went.
Yeah. Well, I'm going to give I have been lucky here in California. I have spoken to consultants in other states. In California, my understanding is the DEA is very busy with illegal drug trade.
Yeah.
So they don't have much time to pay attention. I've had, I believe, 2 DEA audits in my centers in the past 3 years. And they were both from some sort of cause. So, either like one basically doubled their surgeons in a week.
Yeah.
And so they were ordering much more, and that triggered a call to the DEA and wasn't much of an audit. And then another
Once they realized what the real reason.
Another one changed DEAs, because in California you can be under a doctor's DEA in a surgery center, a little weird loophole here in our state. And they changed, but they didn't do it well.
Okay.
And so there was confusion, which caused them a problem, but they did not get into trouble.
Got it.
When we report one loss of fentanyl and nothing else, I have not so far heard from them. That said, for getting prepared for this talk, I have done searches from the DEA press releases, and there are about a dozen already this year.
Yeah.
And in order for it to get in the news, it had to have been not caught by the center.
Yeah.
It had to have been discovered by something else. It had to have gone to court or to punishment in order for it to be a press release. And most of these don't get that far.
Yeah.
So 12 across the country doesn't sound like a lot. Of course, there was jail time in most of them, or money being paid by the surgery center. So there's outcomes that could happen if we don't catch it and deal with it properly.
Right.
If we don't report it properly, we're in trouble for that. If we have, one of the examples was that the center was found to have done batch signing of waste. So they weren't actually witnessing it, they were just signing it at the end of the day.
Yeah.
And that was part of a pretty hefty fine.
Yeah. I've seen the other side too, where they sign at the beginning of the day for the end of the day. I think I've told you about some of those stories. Like, that's not good. Yeah,
I would not encourage that.
Yeah, no.
I would be trying to change that in any center I work in.
Yeah.
And the other piece for the DEA is having your records in order.
Yeah.
It's your Schedule 2 drugs. Paperwork is properly filed separate from your Schedule 3 through 5. You're completing your 222 form or E222 form with receipt. You've got your biennial inventory. I can't even tell you, as I've been growing, about half of the surgery centers I start, even if they've had another pharmacist, don't have a DEA biennial inventory.
And by the way, that is showing up actually as a standard now for HHC. It's only recently that I saw it showing up on one of my line items. So
I need to still get version
4.4 just came out.
Yeah, I need
44. I'm sorry.
I need to get a copy of that one.
Yeah, I will. I'll take.
I've got 43. So yeah, I mean, I'm always looking for those changes in the standards.
Yeah.
It's been the law, so it. Honestly, HHC shouldn't even have to have it as a standard.
Right.
But because half the centers don't, they probably were like, hey, we need to add this in because they're not compliant. So knowing your DEA regulations, honestly, nurses should read them. They're not that long. And
even things like the how storage has to be done. What has to be locked, how securely locked.
My favorite is if you search the DEA regulations for 2 locks, it does not come up. And so what it turns out is that unintended or unallowed entry has to be 20 man-minutes. And that's been interpreted as a steel box with 2 locks. that will take somebody trying to force their way in at least 20 minutes to get in.
Isn't it also pound?
If it's a safe, it has to be some amount of weight or attached to the floor or wall.
Right, so it can't be pulled off again.
So that's why. I've had a client where I'm sitting there counting, and then the cabinet shifts, and I'm like, what just happened? And then I pull it, and it's just not even attached.
Oh, I've had rolling carts that were their pharmacy carts. So I don't think that meets that standard. I mean, you can't make this stuff up, but Greg, that's to the point. Is that I guess that's the next question: security. Mm-hmm. That's probably when I am on site doing a survey, one of the weakest things that I see. You know, the cabinets. Oh, we just open up at the beginning of the day, and we leave them open all day long, and then I hide around the corner just to make sure that at some point, you know, they're not being visualized by somebody.
They need to be in a supervised location.
Right.
So if your med cabinets are behind your PACU counter that there's always somebody at,
I'm all right with that.
Those can be unlocked.
Yeah.
Your anesthesia cart, if your nurse is in the room prepping for the next case, like you have one that goes out and one that's there and that type of thing, and it's supervised,
I'm all right
the
with that too.
anesthesia cart doesn't have to be locked. Yeah. If that room is done, so I have centers that they'll be running one room, but they have 3, and they'll go in and unlock all 3. I'm like, no, the 2 that aren't open, that needs to be locked.
Right.
The med room that's around the corner needs to be locked during the day because it's not supervised. So, that's security for your non-controlled meds. And, of course, security for your controlled meds, they need to be locked at all times.
Right. So what about the movement away from, paper records to a more electronic process? I mean, there's a lot of different products out there, but let's just talk about the electronic approach right now and why we probably should be heading that direction.
Well, digital is the way to go.
Yeah.
If it is efficient for us to do it. It can't be less efficient than the paper forms that we're using.
Right.
And it has to have all the double checks that our paper systems have.
Yeah.
So, I'm still not on one that I'm rooting for completely because I haven't seen exactly what I want yet.
Yeah.
I will work with anybody that my clients choose to work with, but I'm looking for there's a saying that is, if you have a broken system and you automate it, it's an automated broken system.
Yeah, that's a good thing.
So I'm not looking to automate a system that doesn't implement all of the checks and the culture of security that I'm looking for.
Yeah. I
don't want one that looks like a culture of security but isn't, that adds new loopholes into the system.
Yeah.
So, yes, it is absolutely the direction we want to go. We want it to be easy to use, and we want it to do everything that our best practice forms already do.
Greg, as always, it's great talking to you. Thanks so much for spending some time with us.
It's been my pleasure, John. It was great to see you.
Same here.
Next, I had an opportunity to interview my friend Mike McLean. He is with Left Coast Healthcare Advisors. And so the title of his session was, Will We Get Paid? The Art of Trust and Validation When Scheduling High-Cost Cases at Your ASC. But to be honest with you, we didn't talk about that so much. Mike and I work together on a number of things, and he is a very knowledgeable and very active consultant on the West Coast. So we just kind of opened it up, a conversation about what's going on in the ASC industry. So let's listen to that interview.
So I'm here at the 2025 CASA conference. We're out in San Diego, California. What a beautiful day it is out there, Michael. It's great to be with you. I saw you, I think the last time I saw you in person was in, was it Phoenix?
Scottsdale?
Yeah, Scottsdale, yeah. And before that, Washington. You get around the West Coast here. And
I absolutely do.
So Michael McLean, I'm going to have him introduce himself. He's a big fixture on the West Coast, like I guess... maybe people think I'm the fixture on the East Coast, so this is the guy that's on the other coast taking care of things. And you're here speaking at the conference. So first of all, introduce yourself and talk a little bit quickly about what your presentation will be on, and then we'll get into it.
Absolutely, and thanks for saying a fixture. Although you have more hair than I do.
Well, that's very true. Yeah,
I'm the bald guy on the left coast. So as I said, Michael McLean. So I am the a founder of Left Coast Healthcare Advisors. We're a small consulting firm. We're focused on the ambulatory surgery space. So we have clients that are hospitals, ASCs, physician practices, and we're really focused on development, on operations and management, and really helping fill in the how. Yeah. The questions of how do you get from point A to point B. I'm a hospitalist and critical care PA by background, but I've been in this business for 25 years. And like you said, this is a small world, but we all know each other. And so it's great to have a chance to sit down with you, even if it is a tad too humid.
Yeah, well, absolutely. Before we started recording, we were just talking about how the industry is evolving. I mean, I've been in it for 36 years, you about 25 plus years. And it's certainly, I've seen a lot more changes than you have in that time frame, but needless to say, still a lot going on. And I think we're about to go through some pretty dramatic changes. Those cases that surgery centers have relied upon to be the top, the eye surgery, the colonoscopies, the pain management, those will still be there, but they're evolving. And what we're finding is that a lot of much more complex cases are moving into this environment. So let's just start by talking about that evolution and how facilities, how administrators adapt to that, and prepare for, the changes that could be coming before they become victims of the change.
That's such a great point. This industry was built, I think, on three great elements, which was access, affordability, and high quality care. And that's always going to be the cornerstone for our business. But that affordability gets harder and harder when you start to add the high level of complexity that we're seeing. Yeah. That rinse and repeat model that you and I sort of cut our teeth on. It starts to fall apart when you get to spine, to cardiovascular services, some of the complex GYN or urology services. And administrators who've always been chief cook and bottle washers, professional firefighters, you're doing everything, payer contracting.
And kill the spiders,
Kill the spiders, that's right. Shovel the lawn.
That's right.
I mean, I'm originally from Michigan, right? You're out there shoveling and salting yourself.
And cleaning the toilets or fixing the backed up toilets. That's the biggest one, I think.
Exactly. Yeah. And now suddenly, not only are you doing that, but you're having to be an expert in data. You're having to be an expert in contract negotiations. Maybe it's in real estate, an expert in your physical plant modifications, because now it's not just about adding a service, it's about adding equipment, adding size and scale. Right. Maybe it's completely renegotiating not just a contract, but your overall reimbursement mechanism for a new service, including new education tools, new training. That's a lot to take on as a side gig while you're trying to run a business.
So, how do we go about it? I mean, first of all, what are the signs that you think that the average administrator should be keeping an eye out for in their own organization? That maybe it's time to look into some other alternatives or other options.
That's a great question. I think of it as you kind of have to ask yourself about, do you have a time pressure? Suddenly, do you not have enough time? Do you have a new area where maybe you don't have the right subject matter expertise? Are you knocking down walls, getting into regulatory environments? Maybe you have licensing issues you have to deal with. Are you taking on a big liability? Maybe this is new risky patients where you may have to start to touch things like, do I need to change my medical liability insurance? Yeah. And then always contracting. I spent a lot of years in the payer contracting world. Do you have to make big fundamental changes in your reimbursement? Because that can take time, 6 months, 12 months, 18 months. You have to make huge changes. And then cost is always a factor. If you're spending big dollars and you have to buy or borrow money, that's always a time to pause and do you really have the time and expertise to do it, or is it time to look outside and find an expert, whether it's me or you or anybody? Find somebody who's done this work and can help you along the way, because we don't want to learn by trial and error.
Well, and so here's the question: can ChatGPT take care of that for us?
It can give you an answer. Right. The question is, can AIEIO actually solve your problem?
So true. And I do think that's the that's what everybody believes now, is that, when you run into a complex situation, maybe we'll go to AI to get some answers. And, listen, AI is evolving, but it can't solve the complex issues that we're dealing in right now. What do you think are going to be some of the major, what parts of the industry do you think are going to be going down and what are going to be going up? I mean, I think some of it's obvious, but.
Yeah, I think that we've been talking about for a long time, when will ophthalmology move to the clinic? I think they have a strong lobby, but I think that's still always going to be in the back of our mind, much like we've seen moves in pain.
Yeah, right.
When will that shift? I think orthopedics and spine is here to stay in the ASC space. I don't think that's moving. I think that's going to continue to get more complex. GI, interestingly, we have a large number of clients that are hospitals. GI is still predominantly sitting in hospitals.
Especially the more complex or the difficult patients.
Correct.
Yeah.
So I think you're going to see more GI migrate into the ASC space just because it's been stuck there.
But isn't it true that the type of GI cases that we're going to start seeing are going to be more complex? The patients are going to be sicker, and our model hasn't always been conducive to those types of patients.
I think you're exactly right. I think we're more likely to see more complexity within the specialties we see today. Yeah. And then we're going to see some new specialties. We're definitely going to see things like more cardiovascular services, EP, as if what we see in the CMS proposed rule holds, electrophysiology and ablations, we're likely to see start to migrate, which brings on entirely new challenges for our ASC partners. As they think about training, education, and identifying complications, these are all rhythm abnormalities. That's sort of outside our typical comfort area, let alone all the equipment and fixed radiology that you need to go along for the ride.
And you're going to need very expensive equipment and highly skilled individuals that we might not necessarily be currently recruiting or having in our centers.
Absolutely. It changes. It certainly changes the nature. And then we certainly see robotics. If you'd asked me 5-7 years ago, do robotic cases make sense in an ASC? And most of the time the answer was no, doesn't make any sense at all. You don't get any additional payment for it. But robotic cases are getting so good, and if you can negotiate an appropriate contract and you can actually fill that room for the day with robotic services that actually provide a decent reimbursement and a better patient outcome, that's the expectation for patients. So how do you incorporate appropriate robotic services? We're going to see more pressure for that.
Yeah. So it also strikes me when I think about total joints, for example, when we started all these total joint programs, a lot of them really came into the mainstream during the pandemic when the hospitals were trying to offload as much as they can or they could. But there were still these cases, these older patients that we just couldn't take on. That's changing though, isn't it?
I think it's changing radically because and I think this is true of any complex procedure that as physicians and ASCs become more comfortable doing base procedures, they're more comfortable pushing that envelope. And I don't mean it in a bad way. You get comfortable with screening criteria. You get more comfortable with what is and isn't appropriate. And you see this every day as, well, what we used to only be comfortable with an ASA level 2. Now we can do maybe a 3 and a 4 that's completely stable. Because this is the level of service we're going to provide is not going to impact their cardiovascular care. And as technology changes, as surgical approaches changes, the services are less and less invasive. So the criticality of the patient, we're not impacting them cardiovascularly nearly what we did 10 years ago.
So since I have you here, this isn't quite along the lines of what you're talking about here, but what do you think about what's going on with anesthesia right now and how's that impacting the West Coast here? I know what's going on the East Coast, but not so much out here.
What's fascinating is that's a great question. Anesthesia impact, I think on the West Coast is as tough as it is anywhere. The West Coast has always been a heavy MD-centric model of anesthesia. Our CRNA sort of adoption rate, especially in the hospital JV models, have been very low. And accessing high-quality anesthesia services, regardless, has always been expensive. The West Coast has a unique business impact in that for COVID, we experienced COVID early, so our businesses on the West Coast shut down earliest during the pandemic and opened the last as part of the pandemic. So the labor expenses here were already high and magnified. That just increased some of our labor challenges, and that's magnified in our anesthesia providers and in a lot of our physician group practices. So you're seeing stipends through the roof. You're seeing consolidations of anesthesia groups. I have a number of clients that are seeing sometimes 10x increases in stipend requests.
Yeah, that's what we're seeing on the East Coast too.
That it's just been really difficult to manage. That being said, there are still small pockets of anesthesia providers who really have been able to carve out appropriate reimbursement. But as the CMS proposed rule really looks for anesthesia providers, they're not getting the same bump that the surgical services are. And we're going to continue to see a challenge until their reimbursement rises.
You know, Bill Prentice during his presentation this morning kind of pointed out that what he feels is that the anesthesiologists need to spend a little bit more time fighting for better reimbursement rather than fighting or slowing down the growth of the CRNA industry. I'm not familiar with what happens out here on the West Coast on that side, but I do think that is something that is a bit of a challenge in some parts of the country.
I would agree with that. And, being a PA, I've sort of sat in that world of, is it the payer holding us down or is it the physician groups holding us down? And I think you're right, is the argument is to be made with the payers from the reimbursement standpoint, because you can't bite the hand that feeds. And the hand that feeds anesthesia is not the fact that there are CRNAs and surgery facilities and hospitals that aren't willing to compensate. It's that the payers are not compensating them appropriately, and that's where their ire should be focused. I agree completely.
Well, and this problem's not going to disappear anytime soon. It's a supply and demand situation, and we know that the supply can't increase, overnight. Probably take another decade before we're able to get to a more reasonable level. But of course, the reimbursement's going to drive that. I mean, if there's no good reimbursement out there, then it's going to be a bit of a challenge. But these increasing stipends are not sustainable.
They're not sustainable, although what I would say is that I think this is an area where ambulatory surgery facilities and surgery centers in particular, where we shine, because our ability we have an operational alignment with anesthesia providers. We're efficient. We can provide a lot of cases in a short amount of time. That does help them from a level of productivity.
From efficiency.
That's much better than having to sit and do, hour and a half turnovers while sitting in a hospital. You can do case after case after case with short turnovers. So I still think there's an appealing value for that, but it's helping our anesthesia providers understand that there isn't an endless pot of money here.
Right. But to your point, that's a very good point, too, that I've heard said a number of times, is how important it is for our staff in the surgery centers to recognize that we can help the anesthesiologists. We can help our financial situation by making things more efficient. We have great turnover, but we can probably make it even better, or find ways that we can take some of the difficult tasks that an anesthesiologist has off their hands, that don't involve that medical decision making there, and do that.
And that extends beyond just anesthesia. That from a preoperative screening standpoint, from a regional anesthesia, which discharges patients much more quickly, all the way to clinic scheduling. A lot of times, this goes back to your original question about complex cases. Historically, we've been very much focused on what can we control inside the four walls of our ASCs. As we lean into these complex surgeries, as we're getting more complexity, more acuity, we have to be more comfortable on managing services that are outside our four walls.
And outside our comfort zone.
Outside our comfort zone, because in the end, that's how we get paid.
Yeah. And then lastly, we talked about this again before we started recording, that our industry has to remember that we've grown up with the concept that we always have somebody else we can call down the road who can help us out. And I think sometimes the younger generation, the younger people coming in, they don't remember that maybe they don't get out as much. They don't come to these wonderful conferences like you and I are attending here in California right now. And I think that they need to realize that there's a certain point at which anybody is going to need some additional help. So just talk a little bit about that as, kind of reminding our audience about how important it is that there's always somebody out there that can help. Sometimes paid, sometimes, just talking to your friends.
Yeah, and I would say it all starts with your state organizations, your professional organizations, and your network. I mean, you and I both sort of grew up in an industry where we stood on the shoulders of giants.
We did.
We learned from our colleagues, we learned from our friends, and we were never short the ability to pick up a phone and say, hey, John, I'm trying to figure this out. Can you help me? That served us well, and I think it's good to remind our colleagues that that's where you should be starting.
Right.
Look to your local organizations, your state organizations, your national organizations. But the key is knowing your own limits and not being afraid to say, hey, I need some help. And recognize there's a value related to your time. And there's a monetary consequence. If it's going to take you 10 hours to figure it out, can that be better spent compensating an expert?
Right.
And what is that expert? It might be a real estate advisor if you're looking to buy or sell property. It might be a consultant if it's a payer contracting piece. It might be a compliance expert, a mock survey. Sure, you can do your own surveys, but we're all biased.
Yeah.
You can do your own compliance work, but we also know all of our own paperwork.
Yeah.
There's nothing like a third pair of eyes to come through and so don't be afraid to ask for help, because the value in looking outside can be immeasurable. And do it early. Never do it because you'll kick yourself for doing it late.
Well, and so many times, the same thing happens with you. We get into the project way too late. It costs them $250,000, and they say, "I wish I had called you earlier."
Yeah.
Well, I wish you had too, because it's so much more work later on to fix a problem that could have been solved up front.
The other thing that I'll say is there's no free lunch, and we all know this. There's lots of great free content out there. But it's a starting point. So recognize that the really good stuff isn't free. Go out, get a good idea, but know the people. You and I have been in this industry a long time. There's lots of great people. If somebody gets on the phone and says, I can help you and the cost is X amount of dollars, hang up and call somebody else. There's enough really good people who are going to give you some advice, some direction. They may ultimately have a charge, but look for the information first, because the people who know this industry are going to help you first and charge you second.
Right. Well, because we don't want to waste our time either, getting into something that we know we're not going to be able to solve, or you're not going to be willing to pay for the time that needs to be done. Mike, as always, we're going to have you back on again. I know we've been talking, but I thought I'd grab you while you were here in California together, and it's great talking to you.
I just appreciate being in the AC. Thanks for finding me. And in the left coast, we're used to that very narrow range of temperature, 70 to 72.
Well, and I don't know if our listeners don't know this, but in order for us to go from the presentations to the exhibit hall, we have to walk outside, and that's the most painful part of our day.
Absolutely. Rough life here.
It is. Very tough. As always, thanks so much, Mike.
Thank you.
And next, John interviewed Kara Newberry, the Chief Advocacy Officer with ASCA. And she had spoken about the 2026 payment rule and the response by ASCA.
Kara is always a great speaker. She's been on this podcast quite a bit, and I had an opportunity to grab her just before I think she did this actual session. And she was part of a conversation about California and the national legislative issues that were going on. So let's listen to that interview.
So I'm here at the 2025 California Association meeting. We're out in San Diego this year, and I'm here with Kara Newberry. Kara's been on this podcast an awful lot over the years, talking about the various initiatives of ASCA. We're always a big advocate of ASCA, obviously, and I'm going to ask you to talk about that, too, at some point. But, Kara, tell us, first of all, introduce yourself and your role at ASCA, and then let's talk a little bit about what's going on with the 2026 payment rule.
Sure. It's good to see you, John. I am the Chief Advocacy Officer for the Ambulatory Surgery Center Association. I've been with ASCA now for about 14 years, but I primarily handle regulatory affairs for the association, so I know that's what we've primarily discussed. We are right in the heart of the comment period for the Hospital Outpatient Prospective Payment System and ASC 2026 payment rule. And so we can dive into that. But right away, the initial thoughts are that the administration is showing an interest and a desire to create more access to care in the ASC setting, expanding the procedure list significantly. But we do have some concerns, and we will be talking in our comment letter about reimbursement rates,
right.
And ensuring that those are stable so the ASCs can continue to provide the services. I know a lot of people have been talking about there's a cut proposed for cataract. 66984 in particular is our highest volume code. And
a significant cut at that.
Yeah, like a 4% cut to that reimbursement rate, which, there's also a cut on the physician side. So it's kind of a double whammy there. So, raising concerns kind of with how ASCs are reimbursed to try to rectify some of these issues that we're seeing with reimbursement rates.
So you're in the comment period. You're going to be commenting back. Can you talk a little bit about the issues that you're going to be contesting or making a counter argument?
Sure. And comments are due September 15th. So hopefully, if your listeners have specific concerns that they would like to raise, they're also sending those comments directly to the Centers for Medicare and Medicaid Services as well. But ASCA's comments on kind of behalf of the collective industry will focus on 3 areas. Number 1 is reimbursement, and that is kind of twofold. There is our reimbursement update is based on the hospital market basket. CMS has proposed to extend that for 1 more year instead of what has historically been the update used, which was the Consumer Price Index for all urban consumers. The hospital market basket is historically a higher update. Right now, I think it's about 0.5% higher than what we're seeing with, projected CPIU updates. So it is critical that we stay on that hospital market basket moving forward. And then the weight scaler, which is CMS's attempt to maintain budget neutrality in each siloed payment system, that is significantly worse for ASCs this year than in the past. And so we are trying to actually just ask CMS to eliminate that weight scaler. They were only really supposed to apply it the first year that the payment system was tied to hospital outpatient departments payments back in 2008, and it continued for way too long. So we're trying to get rid of that. And so, that would help us on some of these codes like cataract, because it really has the most negative impact on the highest volume codes.
Right.
And then second is the procedure list. Obviously, kind of the biggest deal in this year, in the 2026 proposed rule, was the vast expansion being proposed of the ASC covered procedure list. More than 200 codes that are currently payable in hospital outpatient departments set to come onto the ASC covered procedure list. Of note in that space is cardiac ablations, which we have been strong proponents of and worked in conjunction with the American College of Cardiology as well as the Heart Rhythm Society this year to promote those procedures being added, as well as 2 spine codes, lumbar fusion codes that we have been requesting for years are finally being proposed for addition. In addition to those codes, CMS is proposing the elimination of the inpatient only list over a 3-year period. And it was kind of surprising to us because while the first Trump administration proposed that, this is the first time that CMS has proposed to add those codes directly to the ASC covered procedure list at the same time they're coming off the inpatient only list. And for 2026, most of those codes are musculoskeletal in nature. So, ASCA is supportive of clinical discretion. We are supportive of having the surgeons direct their patients to the appropriate site of care. And so we will be supporting those codes with specific attention being paid to the procedures that we had promoted in the pre-proposed rulemaking portal, which were those cardiac ablation codes as well as the lumbar fusions.
Now, you also mentioned, you were just on the podium a few minutes ago, so I took as many notes as I could. But you were also talking about the new administration having to go through a little bit of an education period here to understand the complexity of this system. We barely understand some of the components of it, so I am sure that is a bit of your challenge right now, especially with the way the actual rates are calculated, as you just said.
And there is a lot going on. ASCs, while, we do now have more than 6,500 Medicare certified ASCs. We still represent a very small portion of the overall expenditures in the Medicare space. And so just making sure that we cut through the noise and ensure that ASC issues are brought to the attention of the policymakers, especially with CMS. We do have a lot of good connections with the political appointees at the Centers for Medicare and Medicaid Services, which helps, but they've been busy just kind of getting up and running again. Right now, as you and I speak, the HHS Secretary RFK Jr. is, probably being grilled on vaccinations. And so there's a lot going on, and trying to cut through the noise and making sure that ASC issues are taken into consideration has kind of been our biggest challenge. But I do think that there is a lot of opportunity, maybe not necessarily in 2026, but 2027 and beyond. I mean, you also have to remember, the first Trump administration, it was that last year, that 2021 rule, that we saw a bunch of sweeping changes. So I was actually impressed that they were able to get organized quickly enough to get a lot of big issues addressed in the 2026 proposed rule.
Well, and also you indicated that there seems to be quite a bit more knowledge of the ambulatory surgery industry among this administration now, too.
Yeah, a lot of the political appointees that we're dealing with were involved. They were worked on the Hill, worked for committees of jurisdiction, which means committees that have jurisdiction over healthcare issues, and so ASC issues are part of that. And so, it's not that same learning curve that you would face if you're dealing with folks who have no background. And then, of course, Dr. Oz, who is the administrator for the Centers for Medicare and Medicaid Services, is a surgeon by background, and so has that understanding. That can cut both ways. Right. Being a surgeon doesn't necessarily mean that, he's going to support ASC issues, but, based on a lot of the codes that were being proposed to be added to the ASC covered procedure list, all indications are that there is, a fairly positive perspective of ASCs there as well. So a lot more to do, but a lot of opportunity, I think, moving forward.
Moving on to Medicare quality reporting, a lot of great changes there. Actually, some really good news for our audience. We've already talked a little bit about it, but why don't we talk about it again and where you are in your position on some of the newest additions?
Sure. And ASCA, we support the removal of the COVID vaccination of all healthcare personnel measure. We oppose that from its very inception. And so we were excited to see that being proposed for removal. It was already removed from the inpatient prospective payment system. So that's a good indicator that it will be included in that final rule that comes out in early November. And then the health equity measures, ASCA had also, raised concerns last year with the addition of those measures. Just we weren't sure that ASCs were the appropriate site of service to collect that data. And so we were happy, and they were never tested in the ASC setting. So we were happy to see that those measures are proposed for removal as well. They have also already been removed from the inpatient payment system. So all indications are that they will be removed from the ASC setting. There is one new measure that has been proposed for addition. And it's not necessarily that ASCA takes issue with the measure itself. It is a information. It's basically looking at was the appropriate information given to patients for postoperative care, so following their procedure. And our concerns stem from the fact that we are just now operationalizing OSCAP's survey. And struggling. A lot of facilities are seeing return rates lower than 20%.
Not even being able to meet the 200.
Having a hard time potentially meeting the 200 completed surveys. So adding another survey, right away, we're seeing survey fatigue from a lot of, patients. And also this measure was not tested in the ASC setting. And so we do have concerns with that. So we will be at least asking for a
because
delay.
It's independent. It's completely separate. And it could have been implemented with OS caps.
So it's interesting because CMS was telling us over the summer that you can actually do it yourself at your facility, but there are questions about how that would be operationalized as opposed to working with a third-party vendor. We do know that there are some third-party vendors looking into getting into this space, but yes, to your point as well, there was a request, well, can we just add a couple of questions to the OSCAP survey? Of course, we all know the OSCAP survey is already long enough, but can we just add a couple of questions there to avoid another survey? And we're told no. So we are going to raise those concerns with that new measure.
We've had some questions from our listeners about the OSCAP's implementation and the ramifications of not being able to get that 200, not being able to even get it up and running on January 1st. Do you have any observations about that?
So I'd asked for something in writing, but of course was not granted that. But verbally we were told by CMS staff that if you did what you're supposed to do and you were working with a third-party vendor and putting that survey out there and just were unable to get to the 200 through no fault of your own, that there will be a reprieve for facilities. We will obviously be reminding them of that in not only in the comment letter, but in upcoming discussions with CMS staff, because, it's not fair. We're already spending thousands of dollars to implement this survey, which of course has taken the place of, other patient satisfaction surveys that facilities were offering that were getting much higher results, probably better information for their facilities. And to get penalized 2% off your Medicare reimbursement as well is problematic. So we will continue to advocate for a reprieve for those facilities who did try to implement.
Thank you. And since I haven't had a chance to talk to Bill in a bit, it's your opportunity to advocate on behalf of ASCA. Can you tell everybody how important ASCA's membership is and how everybody can help you out?
Absolutely. And, we just wrapped up National ASC Month. And so we thank all of our, members who were able to get an elected official into your facility. Even if you weren't able to in August, anytime is really a great time to do a facility tour. We've got tons of tools. We have a toolkit available. So feel free to reach out to me. Happy to put you in touch with the appropriate staff. They kind of can do all of the legwork for you.
Right.
And we have our fly-in coming up in a couple of weeks, so we will be advocating in person with elected officials. Of course, they will be busy. I'm trying to avoid a government shutdown at the end of September. So hopefully we can get some of our talking points out there as well. Just making sure that you are involved with your state and national associations so that you know what's happening at both levels is critically important. There's always, as John, I know John keeps you all updated as well, but there is always something new coming down the line every day, really. So, being involved in your associations is really important.
Well, Kara, as always, it's great talking to you. Thank you for everything you do on behalf of the industry. You're doing a great job. ASCA has been doing an incredible job for us, and I think that the proof is really this proposed rule this year is actually much more favorable to us and has a lot of good news, I think, for the industry.
Absolutely. Good things ahead, hopefully. So thanks for talking to me, John.
Thanks so much.
It's been a long day, and the surveyors just left, and you are exhausted. And looking at the list of items that you have to address, you wonder, how can I deal with this and still take care of my patients? More importantly, you wonder, how can I ever keep up with all of the regulations, standards, and accreditation requirements? How can I always be prepared for a survey and reduce my stress levels? Well, that's what Ambulatory Healthcare Strategies does, day in, day out. We become your outsourced regulatory and accreditation resource. We can maintain your policy manual, develop your education programs, help out with fire and disaster drills, do your risk assessments, oversee your quality improvement activities, help run your quality improvement meetings and governing body meetings, and we can even prepare your monthly or quarterly financial statements and help you figure out where you are financially. We are a retainer-based service. We don't take ownership. We don't charge based on your revenue. We have one fixed monthly fee, and we can tailor your services to your exact needs. So whether you're looking for help getting over a survey, preparing for a survey, or looking for a long-term relationship to assist you with your ongoing regulatory and/or financial needs, please give us a call at 585-594-1167 or email us at info@ahstrategies.com. That is info@ah-strategies.com, or visit our website at ah-strategies.com. California Association is going through quite a number of changes this year with the retirement of Beth LeBoyer. So next, I had an opportunity to interview the incoming executive director, Karen Reiter. So let's listen to this interview as she talks a little bit about the organization and the path forward.
So I'm here at the 2025 California State Association meeting in San Diego, and I'm here with the new executive director for the California Association. And we just interviewed Beth, who is the outgoing executive director. So, Karen, can you tell us a little bit about yourself and what you did before you took on this new role?
Sure. I'm Karen Reiter. I am very excited about being the new executive director of CASA. And my pathway to this role, I have an accent. I'm from New Zealand, been here for over 30 years. And I came to America originally as a registered nurse and then soon became a RN First Assist, of which I was working in that field for a very long time. And then we eventually moved to opening our first surgery center in 2005. Have since been the administrator, operated and done operations for and built and acquired 7 surgery centers. If you asked for my strengths, I would definitely say clinical, regulatory, and operational. I'm really excited about the role at CASA and the strength that it plays and how it interfaces with every surgery center and supports them in their growth wherever they are. My experience within ambulatory surgery centers is a combination of physician-owned, small center, right through to being part of a very large management group and working within that system. And then more recently, we were part of private equity and scaled our facilities. So I feel like that background gives me a lot of insight into the opportunities or difficulties what many of our centers face. And I would love to be able to strengthen the CASA network and be there to support the surgery centers wherever they are.
Karen, what I think is so unique about California's association, in Beth and now in you're people that actually worked in surgery centers, and so we were talking before we actually started recording how, I get around to a lot of state associations, wonderful state associations, and not all of them have actual industry, boots on the ground type people. And I think that's what's exciting is that's what you're going to be bringing to this, as Beth did 20 some odd years ago. And I think that's important for the members to know is that you know their challenges and you know the types of things that they're dealing with.
Definitely boots on the ground, definitely a very experienced administrator of and managing teams and in the clinical setting, working operationally within the facility, knowing how that all interfaces clinically, and then from a regulatory standpoint. Just in the last 2 years, I've gone through 9 surveys, Medicare and AAA, but they, I do think that strength is very helpful because when administrators or centers have questions, they have a resource at the state association that they can call. And if we don't have the answers, we find the answers. We have such a deep experienced board at this organization that we can bring so much to this community.
Absolutely. And now we're already getting ready. You got a couple conferences coming up very soon. Beth introduced them a while ago. But are you getting excited about Monterey?
Super excited about Monterey. Monterey's beautiful location. It's very popular. It's central in California. It's well attended. And just as we strengthen the educational lineup, what we really did see at the 2025 conference here in San Diego, that the educational offering was so strong and so amazing. The main speakers, just very well attended conference, but everybody last night at the event was so pumped up and excited about what they learned.
Karen, I thank you so much for taking the time to we're going to become fast friends over the next couple of years as we continue to support the State Association. I appreciate your time today.
Oh, I'm really excited. Thank you. And thank you for speaking here.
Oh, my pleasure.
It was wonderful.
Thanks.
And last but certainly not least was an interview with Beth LeBoyer. Beth and I have known each other for about 20 years. She is the outgoing executive director for the California Association. I've worked with her since well before this podcast and well before my forming ambulatory healthcare strategies. And she has been a real incredible resource for the ambulatory surgery industry. And not everybody knows this, but she was an administrator of a surgery center before she took on the role of the executive director. So in our interview here, we reminisce about the experiences we've had and certainly the impact that she has had on the California Association. So let's listen to that interview.
I'm here at the 2025 California Association meeting in beautiful San Diego this year, and I'm here with my dear friend, somebody I've known for over 20 years, and we've worked at the state levels before. You've been to our state association, and of course I get here as often as I can, and this is her last year. She's decided to retire, and I'm terribly jealous right now of that. So I thought for one last time I'd get a chance to interview her and talk about things. So first of all, explain your current role and soon-to-be retired role here at the State Association.
Thank you, John. I'm the executive director of the California Ambulatory Surgery Association, and going to head out at the end of the year when we have fabulous replacements. So I'm very excited for the association. But association we established in the late 80s, and we just continued to grow like all the states, and just really, really proud of the membership and the growth of the industry. I think yesterday when I had to reflect with the membership, that was, the one takeaway for me is just where this industry has gone, and everybody should be really proud and excited for the future of it.
When I set up the New York State Association meeting back in 1989-90, I reached out. It was before your time, but I reached out to the State Association, and then, of course, I met you probably, it was about 10 years after that, I believe. And California helped New York a lot. It's hard to imagine, two very large states, but we were just a little baby association in the very beginning. And California, even in those days, was well established and well known. So tell me about this conference. First of all, as you know, I go to so many state conferences, and this is by far the largest one outside of the ASCA conference. So tell us a little bit about your attendance this year and what it took to put together this incredible conference.
Well, gosh, our attendance right at 500. So tracking on, our continued growth, which is super exciting, and the involvement of the membership is fabulous. And it takes months to plan the conference, and we're so blessed that we have tremendous committee members who give their time and were very thoughtful and look at what's going on in the industry and all of that. And this year, being in San Diego, we decided to honor the military, because you look out the window and you see the big Navy ships and the
airplanes going over,
the helicopters, and it's just been a very, very special year. Our program has been. We've had a thread of veterans and their achievements and how that correlates to running a surgery center throughout the program. So it's been fabulous. Yeah,
we haven't been able to interview any of the military people, unfortunately, but I took extensive notes, and that has been, depending upon where this interview shows up on the special episode, we're going to talk about that and some of the experiences I thought really resonates well with our audience. So we did a pre-conference this year. You did something very unique, and I was proud to be part of it too. And I've been pushing it for other state associations to think about. Cindy, talk a little bit about that experiment and how well it came off.
This has been very exciting. So this year we decided to bring back a CASC review and help administrators kind of go through all the things you need to, in running a surgery center. And not necessarily a CASC review, but it does cover all the things on the CASC exam. And then we gave members or anyone the opportunity to take the CASC exam on site. And the enrollment for the review was incredible. So I think that's something that the industry is really clamoring for, and something that could be replicated across the states.
Yeah, and actually I talked to Deb Stitchcomb yesterday, and we're going to do a special episode. We're going to talk a little bit about, or a lot about, the CASC and what it does for the industry and some of the initiatives that are out there. And I believe simultaneously with the review course or that administrator track, there was one for the director of nursing too. Can you talk a little bit about that?
Yeah, so we also put it as a side-by-side conference for DONs, directors of nursing, and just talking about all the things that they need to, fill that role. Mm-hmm. And you look at all the turnover in the industry, or sometimes they just get promoted into the role and don't have those resources. And the attendance for that was really incredible too. So it just makes you feel good that you were able to find something really useful for the members.
So how many members do you have right now, and how many ASCs are in California? I don't always keep track of all of that.
Well, gosh, and it's a growing number all the time. Yeah. But we're right at 460 members, and almost 400 of those are facility members because you have auxiliary and individual. So that's really exciting. And then in California, it's right around 800 surgery centers. And that would be like Medicare certified.
Correct.
Because there's a lot of facilities that, fall under more of an office-based or, not Medicare certified. But I like to use that as our benchmark. So almost 50% members. Always opportunity for growth.
Absolutely. Talk a little bit about some upcoming events. You've always got a very full calendar for the state association members.
Yeah. So, the next big event is our infection prevention seminar, and we started that in 2008, and it has just grown every year. And we try to cover everything that, if somebody was a CAPE, that they would get those units for that, and then. Changing it up every year to make sure we're trying to hit the hot buttons for infection prevention. So I'm really excited for this year's program. We've got some new speakers, and it's just one of the things our members really, really appreciate because it's so in-depth.
And it's so necessary to keep current with what's going on in the, for regulatory purposes and for surveys.
Right. Correct. Yeah, and then we're finishing up. We've done a year-long webinar series on the employment cycle. So all the things, as when you're a manager, from the hiring process to discipline to leaves to social media, and that's been a great tool for our members that they can access that education.
Wonderful. And then you always have a great exhibitors section here. And we have a lot of listeners that are exhibitors. So can you talk a little bit about the exhibitor experience and how I've talked to virtually all of the exhibitors here myself just because I tend to wander during that time. I haven't heard a single person who has said that it wasn't an incredible experience. So hopefully you got that feedback too.
Oh, that's great. We try really hard to make the experience for our vendors and sponsors super positive and incorporate as much as we can that they feel they get that integration, and our members get to see, the latest products out there, and we provide those connections. So we couldn't do these conferences without them. And there's so many exciting things happening in the industry. From all the programs to help with compliance to the billing and revenue cycle, and now we're getting some AI companies and robotics, all those things your members know that's happening within the industry, and the vendors are just so critical, and I can't keep up with everything that's happening. So
and it's changing rapidly. The AI is impacting the industry so much. I imagine a quarter of your vendors next year are probably going to be all AI oriented, and some of them we probably never even heard of or even know about now.
Exactly.
Yeah. And talk a little bit about membership, how you become a member, why you would want to become a member. I think we've already kind of given a good hint as to why you want to become a member, but.
Yeah, so absolutely. Membership in a state association, whether it's California or anyone across the country, is so critical. Yeah. We try to provide all those things, education to make sure you can run a surgery center, but more importantly, for every state and for especially in California, being part of those advocacy efforts. Yeah. There's so much happening, so many things that were there. ASCs used to be under the radar, but they didn't think about them much. And now they're like, oh, these are a critical part of healthcare and access. So how does that fit in? And if we're not at the table, we're not providing that voice or education to our legislatures, they're going to, decide it for us. Yeah. So that's one of the critical components. When you're so busy running a surgery center, I think sometimes you miss that. So membership with that is super important. Plus all the tools and I think the one thing that you can't put tangible on it is the connection and the community. And the ability to interact with others and get the mentorship and learn from each other and provide that support.
Yeah, text a friend or call a friend. Yeah, that's a very big thing. And I've met so many people here, many that I've met over the years, but new friends. And I love watching, people get to know each other, that, nobody's shy about going up and saying hi.
Yeah.
And lastly, just, kind of reflect a little bit quickly. I mean, I know both of us are, this has been a long time that we've been together and different things. So, what are your last thoughts here as you move into retirement?
Oh, well, like I said, when I started, talking about the ASC community and how special that is, I am so excited for the future for surgery centers. And I would hope that people are involved in their state associations, whether that's CASA or another state association, and provide that community. And I think at all levels, I'm so excited by the leadership and the innovations, and I think the future is super bright.
Well, it's a testament to your leadership that the people that you've brought up and the organization's not going to be in trouble because you're leaving. I think that's important an important lesson for everybody out there is that, good leadership and mentoring helps the next generation. On behalf of the industry, I just want to thank you for everything you've done.
Thank you, John. And I would love to say to all my friends in California and like you across the country, we established these relationships. And for me, they were a lifeline.
Yeah.
When I ran a surgery center as well as part of CASA. And that is the most wonderful thing about the ASC community is the collaboration and connection. And I think I said yesterday, it's unique where competitors collaborate.
Yeah, so true. And even if they're in the same community, you still see it.
Yeah, I think that's just something very unique to our industry.
Yeah.
And that's something that makes me proud.
You should be. Thank you so much.
Thank you, John.
As always.
Okay.
As always, we want to thank the California Association, for this opportunity to record this special episode during their wonderful conference. And, of course, congratulate Beth on her retirement and wish the organization its continued success as it moves forward. In our show notes, we're going to give you information about how to join the California Association so that you can experience the conference next year in person yourself.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.